Welcome to Going Antiviral, the podcast for the IAS-USA, a professional continuing medical education organization focused on HIV and other viral diseases. I'm Dr. Michael Saag, professor of medicine and infectious diseases at the University of Alabama at Birmingham and volunteer member of the IAS-USA Board of Directors. Welcome to the Going Antiviral podcast. Today, May 3rd, 2024, we are speaking to Dr. Todd Brown, who's professor of medicine at Johns Hopkins School of Medicine. Dr. Brown is an endocrinologist who focuses on body composition, metabolic, and skeletal abnormalities observed in people with HIV, particularly as it relates to aging. Dr. Brown's research focus on understanding the pathogenesis of glucose disorders, fat changes, hormonal dysregulation, and osteoporosis in people with HIV, as well as the consequences of these conditions and their optimal evaluation and management. Along with a few of his colleagues, he reviewed the topics of HIV metabolic complications presented at the recent 2024 CROI meeting as an upcoming article in Topics in Antiviral Medicine. Todd, great to have you with us. We're going to talk about those things today. Welcome to the broadcast.
Great. Thanks, Mike. Great to be here.
So we got a lot to cover and a lot of really interesting things that were at CROI, and you guys did a great job of summarizing those. And this review article will be out probably in the next 4 weeks or so, so people can keep their eye on the IAS-USA website, as well as looking in PubMed for the release of that review. But we're going to get a preview of that today. It's kind of exciting. So one of the things you guys highlighted was high blood pressure management, especially in low and middle income countries. What did you guys see there?
Yeah, I mean, blood pressure, of course, is a major cardiovascular risk factor, one of the most important and obviously modifiable. So we have great medications that can control blood pressure. And hypertension in particular, we know among people with HIV, in addition to some, risk factors related to antiretroviral therapy and immune dysfunction, traditional risk factors are really just key in trying to prevent cardiovascular events. And, blood pressure obviously is one of them. If you look across the board around the world, and particularly in low and middle income countries in Africa and Haiti, high blood pressure is really a major problem among people with HIV, a major problem in people without HIV. And so there are a couple studies that were presented at CROI that I think are really super relevant. These are, implementation science studies. So we know that blood pressure needs to be controlled to reduce cardiovascular events. We know that we have good ways of doing so and lots of good ways of doing so, and that are relatively inexpensive. The important thing is to get people on these regimens, get their blood pressure controlled, and have them stay on these blood pressure medicines to keep it controlled in order to decrease cardiovascular risk. So there are three studies that really stood out to me, all that were in the oral session for the complications about blood pressure control. One of them was done in Haiti. Again, blood pressure is a big issue. And in this one looked at pre-hypertension. And so, just as we have in diabetes, you have people who have normal sugars, you have people who have sugars in the diabetic range, you have people in this sort of pre-diabetic range. Same thing with hypertension. So the idea here is that if you can intervene earlier on people, then they won't progress to higher levels of blood pressure, which are associated, the risk related to blood pressure in various events, say kidney disease or cardiovascular disease is really, blood pressure dependent. There's a dose response effect. The higher the blood pressure, the worse the risk. And so if we can intervene earlier, then perhaps we can sort of not need to intervene as much later. And so this was a study where they took people with pre-hypertension and HIV and randomized them to either standard of care or going on amlodipine. And so amlodipine, common drug, calcium channel blocker, very inexpensive, very effective. And lo and behold, they found that but at the end of the study interval, that those people who were randomized to active treatment were less likely to progress to hypertension. And so this really raises the question, well, at what level of blood pressure should we intervene? Should we wait till 140, greater than 140 over 90, or should we have to intervene earlier, like you would in someone with diabetes or someone with chronic kidney disease, given that the known consequences are more common in that population, and knowing that the risk of cardiovascular disease is higher in people with HIV. So really, so the study sort of worked in that it did decrease the progression to hypertension. But I think that it's really important to think about this as we treat our patients. We all have patients who have this sort of borderline blood pressure, and we hem and haw. Should we put them on medication? Should we not? This gives us some proof that putting them on medications is helpful, at least in the short run, in terms of blood pressure control. Whether it improves, other associated clinical outcomes is another question.
So a couple quick follow-ups. This is, as you said, very common, and we tend to delay, and I think that may be a mistake. What are you doing in your practice when you talk to folks at Hopkins or elsewhere about when to intervene? What would be your recommendation?
Yeah, I think that the pendulum has swung all over the place, as far as when to treat, and I think that part of it is tolerability, and you want to be sure that you have a medication that's tolerable, but I think that intervening in this pre-hypertension phase, does make sense if the person can tolerate it.
Right. And how do you tell if somebody's taking their medicine? Because with antiretroviral therapy, it's pretty straightforward. Their viral load shoots up. And blood pressure, it can vary. Sometimes white coat syndrome makes it go up when they're seeing us, and it's not so high at home. Do you find that there's resistance, if you will, to taking this extra medication just for blood pressure, which is kind of hard to communicate about?
Yeah, that's part of the issue with the blood pressure. It's a hard thing to message because it's asymptomatic, and you don't have anything demonstrable. And as you mentioned, the values that you get in the office may not reflect the values that they're getting at home, when they're sort of in a sort of calm environment.
And you mentioned cardiovascular risk, which is of course a big deal. In my neck of the woods in the South, but it's everywhere, I guess. We're really concerned about progression of kidney disease. And,
absolutely.
And I'm finding that getting better control of blood pressure earlier makes a big difference there.
Yeah. I think there's a lot of good reason to sort of not to be susceptible as a clinician to inertia. To say, well, let's see what happens next time. Just these are medications that have been used for a long time. They have some side effects, but relatively few side effects. And there's a whole bunch of different blood pressures, of course, to choose from. Right. I tend to be pretty aggressive.
So final question on this. On the flip side, how often are you seeing that when you initiate in this pre-hypertension phase that you bottom somebody out? Have you had that as a complication?
Yeah, not really. These medications work, but don't work a ton. I'm always a little bit worried in older patients, for example, who might not tolerate, lower blood pressures as well. People at risk for falls, for example. But with 5 of amlodipine or, low dose ACE inhibitor or angiotensin receptor blocker or hydrochlorothiazide, they'll lower the blood pressure, but it's rare to see someone get blood.
Right. And so it doesn't sound like there's a whole lot of downside to pushing the pendulum to a little bit of earlier intervention. So
That's right.
on the topic of cardiovascular disease, it's not just controlling blood pressure, but a lot of folks in the HIV field especially, are very familiar with the Reprieve study results, which basically showed that if you take people who are, say, between the ages of 40 and 60 who don't have an indication specifically for statin therapy, randomize them to either getting a statin or not in a blinded study, lo and behold, there was a significant reduction in cardiovascular events. So in other words, we're treating people who otherwise wouldn't have been treated earlier and seeing benefit. And at the CROI meeting, as your team reported, several follow-on studies. Can you give us a sense of what those were talking about?
Sure. Yeah, so obviously the Reprieve study has been really important in trying to manage cardiovascular risk, and I think it's going to have a major impact on the health of people with HIV. You know, a few interesting things about Reprieve, about their main results, is that the benefit in terms of decreasing cardiovascular events sort of went beyond the degree of LDL lowering. So, you know, pitavastatin is sort of a moderate statin, and, you know, LDL did go down, but the amount of risk reduction that they saw was sort of out of proportion when you look at studies from the general population. So it suggests that there's other stuff going on that's getting improved with pitavastatin, including systemic inflammation.
So do you think that's it? Do you think it's as simple as reduction in systemic inflammation, or is there some other mystic quality of these drugs?
Yeah, and so this one of the studies that was presented was a really interesting study. You know, we've been using, you know, the field and lots of fields have been using proteomics to sort of understand, you know, what things go up, what things go down with an intervention or in a given population versus another. So one of the oral presentations took a proteomic approach and said, okay, what are the proteins that change in pitavastatin versus placebo? And which of those proteins are associated with a regression in non-calcified plaque? So in Reprieve, you know, big study, you know, 7,500 people. There was a sub-study of about 800 people where they did CT angiograms to look at whether or not pitavastatin changed plaque progression. So CT angiography really get really nice views of the heart. In particular, they were looking at non-calcified plaque. So in the process of atherosclerosis, you get plaque formation, the plaque grows, you get maturation of the plaque with calcification. And so, you know, with extensive plaque, usually you see lots of calcium if you were to do a calcium scan of the heart, for example. There is some plaque that does not become calcified, and that plaque, you know, may not be obstructive, it may not be obstructing the flow, but it's more vulnerable to rupture and to leading to trouble. And so, the primary endpoint for this sub-study was looking at at cardiovascular progression, atherosclerosis progression, mostly focused on this non-calcified plaque, which is higher in people with HIV. So we've shown it in the MAX. Steve Grinspoon has seen it. So and it showed that this in a study that was published last year, that pitavastatin in Reprieve was associated with a regression of non-calcified plaque. So they went to, so getting back to this proteomic study, they said, okay, what proteins changed with pitavastatin and changed with, were associated with regression of plaque. And it turns out that it wasn't what people thought, you know, so it wasn't what in a separate study, the authors looked at oxidized LDL and LDL itself and other markers, and it wasn't changes in those that was associated with regression plaque. It was a protein called PCOCE, so POLC, which is it's a collagen, so it's related to fibrosis. It's a pro-collagen type molecule. So why that particular molecule seemed to be so important, it changed with pitavastatin, it was related to plaque. Nothing that, you know, you necessarily, it doesn't have necessarily an action that you think about necessarily in the pathogenesis, but it could be, then this is what these proteomic studies tell you. They give you, some inkling perhaps into what pathways are important here. And it could be that this process, of collagen changes in fibrosis, that these have important actions in terms of the pathogenesis of plaque formation and the effect of pitavastatin on changing plaque progression. So right. It does give us a little insight. It doesn't tell us the answer that, and can we intervene on this directly? But it was sort of interesting in trying to understand exactly how does pitavastatin work in this population.
It does demystify it a little bit as opposed to just waving hands and saying it's magic, for sure. So one of you mentioned the quote, more potent statin agents, like simvastatin, one of the first ones. We don't use in HIV very much because of drug interactions, but it's viewed as a relatively weak statin compared to, say, rosuvastatin or some of the others.
Sure.
Do you know of any data that talks about this collagen proteomic factor being just as effective with simvastatin versus rosuvastatin? Or something?
So I honestly haven't looked at it, but I think it's an important question. And with all of this, with all the reprieve findings, is the generalizability, and how much is we'll never know, because there'll never be another reprieve with atorvastatin or rosuvastatin. Right. And so how much of this effect is specific to pitavastatin, unclear. We think my general feeling is that is generalizable, like the cardiovascular benefit that you see in people with HIV is generalizable to rosuvastatin or to atorvastatin. I mean, we don't know that for a fact, but I don't, honestly, I don't use pitavastatin a lot. So I think that would be a really interesting question to know. Say, take the rosuvastatin study that Grace McComsey did, Saturn, and to look at this specific factor, because if so, then it gives us an inkling that it's acting about the same as what you see with pitavastatin. So it gives you a little bit of peace of mind. Well, maybe rosuvastatin would be just as effective for pitavastatin for decreasing cardiovascular events.
Right. So we're talking about drugs that were developed in response to Brown and Goldstein at UT Southwestern in the 70s and 80s as they discover the enzymes that are inhibited in the liver that are responsible for LDL production, et cetera. And here we are 50 years later, still fine-tuning exactly what these drugs do. And I think what's interesting from all this is that, their focus on LDL, HDL, which everybody almost has as household words nowadays or phrases.
Sure.
There's more to the story, and it's kind of interesting to watch that unfold. Speaking of new drugs that have been around for a little while, the other talk of the meeting from my perspective was on the GLP-1 agonists. Besides being bombarded every time we turn on a sporting events on TV or other station, we get these commercials for GLP-1 agonists to jingles that make you just want to leave the room. But these would be things like semaglutide, sometimes referred to as Wegovy or Ozempic and that type of thing, and variants on that. But to me, at this meeting at CROI, there were a list of posters that were somewhere around the 790 area, and I called it Semaglutide Alley because there was one after another. Weight loss, but also reduction in liver fat and reduction in there was improvement in cognitive ability and reduction in cravings and reduction of addiction potentially. I'm like, and holy smokes, what does this stuff do? So what's your take as an endocrinologist who's probably been working on these for at least a decade or longer because they were discovered, in the early 2000s? What's your take on these drugs in general and specifically in the HIV population?
Yeah, I mean, they've been a game changer. There's no question in the endocrine world. There was a theme discussion, and I gave a little spiel at the beginning about these drugs, and they have really revolutionized the treatment of diabetes and obesity. So on the diabetes side, metformin had always been the sort of the go-to drug. Everyone agreed, when someone has diabetes, you start them on metformin if there's not a contraindication. And they tolerate it. But with the power of these drugs, both decreasing hemoglobin A1C, decreasing weight, and probably most importantly, decreasing cardiovascular events. It's really changed how we manage diabetes. They're well tolerated, relatively easy to use. You have to go up, start at a low dose and go up slowly. And honestly, the most difficult thing now in the management of people with these drugs is finding the drugs. There's just a shortage all over the place, and there's not a day goes by when I don't get a epic message from someone saying I can't get my Ozempic, I can't get my Trulicity, et cetera. But there are GLP-1 receptors all over the place, and all over the body, and so I think we're really just at the beginning of understanding the impact of these drugs on multiple systems, both on the positive side and the negative side. So the positive sides are really quite remarkable in terms of the A1C lowering effects, as I mentioned, and A1C lowering it without causing hypoglycemia. So if you give a drug like a sulfonylurea, which we're all, sort of grew up with, glipizide, glimepiride, et cetera, also releases, insulin, from beta cells, but it cause insulin release no matter what the glucose is. So, hypoglycemia is really common. These drugs cause insulin release, increase beta cell function, but only when the glucose is high. And so it's really, pretty remarkable how, we have this endogenous hormone that we've been able to. We have this endogenous hormone, period, but we have this endogenous hormone that we've been able to model and have this agonist that works so well, lowering hemoglobin A1C. The weight loss effects, are pretty impressive, and with the dual agonist, so you have, semaglutide is a GLP-1 receptor agonist. Tirzepatide is a twincretin or dual agonist. So it's an agonist to both GLP-1 and another gut hormone called GIP, and it has even more profound effects on weight. And so these receptors, the GLP-1 receptors and GIP receptors, are in the brain and the hypothalamus, where their activation leads to weight loss, and with weight loss that sort of rivals what we're getting up to where you see with a surgical intervention. Yeah. And so these drugs have been super important, but the cardiovascular benefits, as I mentioned, really have been a game changer. With very impressive effects in people with diabetes. And also there was the SELECT trial that was published in the New England Journal showing that even people without diabetes but who have cardiovascular disease, you can decrease the risk of another event. And so this is going to pave the way, I think, to opening up these drugs, assuming we can get them, to a larger population.
It's fascinating because just thinking back to medical school, traditionally we sat in lecture halls for 2 years before we ever saw patients. That's changed a little bit, but everybody kept saying, what's the relevance of me learning about glucagon, or what's the relevance of me learning about GIP, that active peptide from the gut? And all of a sudden, here are drugs that use those mechanisms, GLP being glucagon-like peptide. Now we have to, if you're an endocrinologist, you would know, but if you're just an internist or others, you have to go back and relearn your basic science a little bit. It's okay. It's good. It's kind of cool.
And so definitely very exciting. There are a couple of the downsides. We can talk about the downsides, which are important to talk about. So, the the slowing of gastric emptying can be a real issue for people. Relatively rare side effect. The nausea, of course, and that's why we start at a low dose and go up very slowly over time. One thing that we saw is that we've seen is a decrease, in addition to decreasing fat mass, you have a decrease in muscle mass.
Yeah.
And so this leads to the question, okay, well, why is that bad? Are we going to lead to a decrease in muscle function with that decrease in muscle mass? And there's some data in the from the registration trials for semaglutide that showed the same thing, but then they looked at physical function changes. Physical function actually got better with semaglutide. And so one of the studies that was presented looked at a single arm study in people with HIV, looking at the effects on liver fat. And that's another potential benefit, is decreasing liver fat, which we can talk about in a second. But in this analysis, they looked at changes in psoas muscle volume. So sure enough, with semaglutide, psoas muscle decreased. But interestingly, physical function tests were done. So grip strength and walk speed and standing up from a chair. And it turns out that with that decrease in muscle mass, it didn't seem to be any decrease in physical function. In fact, most of these parameters actually improved over the interval. And so only, they were borderline p-values. It was a small study, but it does make you think about this potential disconnect between muscle mass and muscle function. Yeah. And the other caveat here is the age of the population. And so where you weren't talking about people in their 50s, it could be quite different if you're giving these drugs to someone in their 70s, for example.
Yeah.
And so that's something to be cognizant of.
So we're going to have to unfortunately wrap up, because this has gone by very fast, as I sort of knew it would. Where do you think we're going to be in the next 5 to 10 years? These drugs are so transformative. Assuming the supply keeps up, which they've got all kinds of financial incentive to do that. How do you think we'll be using this in HIV?
Yeah, I think we're just beginning to understand these drugs, really, and we know that these drugs decrease systemic inflammation, and there's another study that was presented. To the extent that systemic inflammation is driving the comorbidities that we see, so it might be a really important. And then I should say that this decrease in systemic inflammation is not related to the decrease in fat that you see. And so, I think we need to know a lot more. I mean, and one of the slides, as I was preparing this talk, I did a quick PubMed search. I did GLP-1 receptor agonist, looked at the changes over time in the number of citations. And there are like 1,400 papers a year in the general population about these drugs, and the curve is exponential. In HIV, there's like 2 papers a year, and they're not even. And so this was the really first time that we saw any data for these drugs in people with HIV. So I think we're really, really at the very beginnings of what we could.
And there's no question, I think, because the weight gain that folks have been seeing with antiretroviral therapy, nothing seemed to work, including metformin. Changing antiretroviral medicines didn't have any effect. Yeah. These medicines seem to have an effect. And so I suspect we're going to be using them more and more. And I think we'll be looking at longer acting everything, maybe longer acting blood pressure medicine, longer acting antiretrovirals for sure, and maybe some longer acting GLP-1.
Yeah. And then dual hormones or triple hormones, the pipeline is just really full coming through, which will put different market pressures on there. But, I think that it is really something to watch now and going forward.
Well, thank you so much for joining us today, Todd. This has been provocative, informative for sure, and really stimulates a lot of thought about not only where we are, but where we're going to be in the next 10 years in terms of blood pressure control, reduction in cardiovascular mortality, morbidity, and also control of weight and glucose, among other things. So it's a really exciting time to be in HIV medicine, and you've been leading the way along with several others in this field. So very grateful for your time to be with us today.
Great. Thanks, Mike. Thanks for the invitation.
Thank you for listening to this episode of Going Antiviral. Catch up on earlier episodes wherever you listen to podcasts, and check out the video versions of this episode and others on the IAS-USA YouTube channel. You can find these links in the show notes, or simply go to YouTube and search for IAS-USA, and there they are. Be sure to subscribe, rate, and review Going Antiviral on Apple Podcasts. This podcast is for informational and educational purposes only and is not intended to serve as medical advice. Opinions expressed in this podcast do not necessarily reflect the opinions of the IAS-USA or its affiliates. If you have a question you'd like answered on the show, you can send it to podcast@iasusa.org to be answered in a future episode.